Good morning, good afternoon, and good evening. Hello, everyone. Thank you for your time and attention today. My name is Sean Arayasirikul. I'm a research scientist at the San Francisco Department of Public Health and an assistant professor at the University of California, San Francisco. I'm really excited to be here talking to you all today about an intervention that I hope piques your interest. This webinar is entitled Healthy Nav, which is short for Healthy Navigation, Implementation of a Digital HIV Care Navigation Intervention. I plan to cover a lot of ground today. First, I'll tell you a little bit about myself, how my biography has shaped my approach to developing mobile health interventions for people at risk for and living with HIV. I will frame the background of digital HIV care navigation and lay out a few learning objectives for today's webinar. Next, we will dive deep into Healthy Nav. I will provide an overview of Healthy Nav and review the conceptual frameworks that have informed the development of this intervention. I'll outline the specific intervention components, study design, and intervention setting, as well as the population of focus. I'll walk you through our findings and results from our evaluation of Healthy Nav in three key areas: feasibility, acceptability, and efficacy. I will discuss the novel contributions of digital HIV care navigation in providing just-in-time support and care. And I will close our time by sharing some lessons learned. The specific objectives of this webinar are to describe the components of a digital HIV care navigation intervention, understand potential use cases, and identify strategies and lessons learned in the implementation of a digital HIV care navigation intervention. And this webinar will serve as a technical assistance resource for Ryan White HIV/AIDS program and the broader public health community. And I'd like to acknowledge and thank HRSA for funding the Healthy Nav intervention. The context of this webinar do not necessarily represent the official views of, nor is an endorsement of HRSA, HHS, or the US government. I do not have conflicts of interest to disclose, and this webinar is supported by another HRSA award. Now I'd like to provide information about NASTAD and the Center for Innovation and Engagement, or CIE. NASTAD is a national nonprofit representing public health officials who administer HIV and viral hepatitis programs funded by state and federal governments. This includes all 50 US states, the District of Columbia, Puerto Rico, the US Virgin Islands, 7 local jurisdictions receiving direct funding from the CDC, and the US Pacific Islands. NASTAD's work includes interpreting and influencing policies, conducting trainings, offering technical assistance, and providing advocacy mobilization for US health departments. The Center for Innovation and Engagement is funded by the HIV/AIDS Bureau at HRSA under Part F, or Special Projects of National Significance funding. And the center's goal is to identify, catalog, disseminate, and support the replication of evidence-informed approaches and interventions to engage people with HIV who are not receiving or who are at risk of not continuing to receive HIV healthcare. The Center for Innovation and Engagement, a project of NASTAD, provides innovative evidence-informed interventions that supports linkage, re-engagement, and retention in care to help end the HIV epidemic. By visiting the center's website at ciehealth.org, you will find a wealth of resources, including intervention implementation guides, provider tools, calculators, and specific information about how to request technical assistance and more. An example is the Positive Links Intervention Implementation Guide, which is a clinic-based mobile health intervention that promotes linkage to and engagement in HIV care in rural areas for people living with HIV who are new to care or at risk of falling out of care. And before we get into the topic at hand, I want to make space for contextualizing my own positionality. Yes, I am a behavioral scientist, but that shouldn't obfuscate the unique perspectives and potential biases that any one person may bring to the table who didn't have to endure years of graduate and postdoctoral training. Addressing the lived experiences of the populations we serve must include those of us who have a role in the delivery of HIV prevention and care services. And I grew up in an immigrant, working poor, Southeast Asian family on the border of Los Angeles and Orange counties in Southern California. I was the first person in my family to go to college. Grew up in a time where going to college was a means to escape one's upbringing. And in college, I came to my queer identity, struggled with isolation and internalized stigma, dropped out of college, survived homelessness as a young sexual and gender minority of color in Los Angeles. And my lived experiences at the margins of society have framed how I navigated the academy, social structures, HIV prevention and care, and research. I'm a mixed methods medical sociologist. I share this because quantitative data in the form of numbers and statistics are important, but the stories, experiences, and voices in qualitative data are just as important, if not more powerful. This leads me to adopt frameworks that center intersectionality and anti-oppression in achieving health equity. And lastly, I believe in the internet and mobile technology. As a preteen, when the internet was made available to the public in 1993, I was part of the generation that went from practicing cursive handwriting on pre-lined paper one day to typing green font on a black screen the next. The first time I had met other people like me or found validity in my own identity was on the internet. I believe that mobile technologies, when harnessed thoughtfully and from the lived experiences of people on the margins, it can facilitate meaningful connections, not only between friends, but even between patients and providers. The internet allows many people, especially sexual and gender minority youth of color, freedom to explore their identities, the wholeness of who they are, as well as the many niche aspects that make them uniquely themselves. While many might see me at a conference or at work or even on this webinar as a professional through one specific lens on the left, or on Facebook and Instagram on the middle on the right, you'll know I have a passion for fashion and being part of the house and ballroom community. The internet allows me to be my fullest self, embedded in a community of people like me. I bring all of this to my work in developing Healthy Nav, or Healthy Navigation, a digital HIV care navigation intervention. And more Americans than ever are using the internet and have access to a mobile phone. According to the Pew Research Center, an overwhelming majority of American adults report using the internet, report having a mobile phone, and specifically a smartphone. And many use social media, with the most widely reported platform being YouTube, followed by Facebook and Instagram. Of those who use Facebook, 70% report using it on a daily basis. The world as we know it has changed in the past 2 years, and we can bet that it will continue to change. And while the interest in digital health approaches has risen over the past decade, it has skyrocketed since the global COVID-19 pandemic. This has led to greater access to and interest in delivering telehealth through virtual communication technology, such as teleconference or video conference, mobile health or mHealth technology using text messaging or apps, the use of patient portals and email messages, as well as social media. And at the intersection of dual epidemics, HIV and COVID-19, HIV care and public health systems have a responsibility to plan for and mitigate potential disruptions in care. A recent study published by Spinelli et al. Found that in a large urban HIV clinic, viral non-suppression was 31% higher post shelter-in-place policies. COVID-19 has exacerbated structural inequity, impacting the most vulnerable in our society, especially youth and young adults and those with high social need. And getting into Healthy Nav. All of this work has led to the development of Healthy Nav, a 6-month digital HIV care navigation intervention using SMS text messaging. We connected 120 young people living with HIV with their own digital HIV care navigator. The digital HIV care navigator provided participants with social support, referral, and linkage support, and motivational interviewing to support behavior change. And participants also completed daily surveys about their general health called Ecological Momentary assessments. We followed participants for 18 months after enrollment at baseline, and participants were recruited from a diverse service system in San Francisco. And of course, it's important to consider the conceptual underpinnings of interventions that you implement. And to improve outcomes in the HIV care continuum among young gay and bisexual men or other men who have sex with men, and trans women living with HIV in San Francisco, I drew upon the expanded chronic care model and the patient-centered medical home model. The expanded chronic care model promotes high quality chronic care and ongoing quality improvement activities, linkage to community resources, and the use of individual and group interventions that empower patients to take an active role in their health. The patient-centered medical home model uses a care team approach to provide patient-focused, culturally relevant services, strong patient-provider relationships, and the elimination of barriers to care. Again, HealthyNav is a 6-month digital HIV care navigation intervention using SMS text messaging and consists of 4 main intervention components. We provided young people living with HIV short-term mobile phone access, delivered asynchronous, non-traditional digital navigation through text messaging. We collected ecological momentary assessment data and integrated that back into the digital navigation system in real time, and leveraged social media platforms to locate and retain participants in care. Our overall goal was to improve HIV care continuum outcomes, specifically support participants' linkage, engagement, and retention in HIV care, and increase adherence to ART to achieve and sustain viral suppression. HealthyNav leverages mHealth and text messaging to connect young people living with HIV to their own personal digital HIV care navigator. And for a period of 6 months, we delivered personalized on-demand social support and tailored engagement in real time. We utilized theories of social support and motivational interviewing to scaffold and structure change talk to identify and act on barriers to linkage, engagement, and retention. Ecological momentary assessments, or short daily text message surveys, are a unique component of HealthyNav. In a clinical encounter, you may have patients presenting in crisis or with an urgent acute need, like restarting ART, getting treated for an STI, etc. But not only are patients engaging with the healthcare within this narrow purview that is often urgent, there are also time constraints on the clinical encounter, and developing the rapport to deliver whole person care takes more time than you might have in a busy clinic day. Ecological momentary assessments extend our ability to know what's going on outside of the clinic walls in the daily lives of young people living with HIV that might lead to an urgent healthcare need. Here you see that on the left, I have a figure that shows that there is a lot that may be happening in the moment in the real daily lives of young people living with HIV. And EMAs allow us to understand these unknown triggers that young people navigate on a daily basis. These important social, emotional, environmental, and contextual factors are critical to shaping behaviors that impact engagement in HIV care. And they inform, in the middle, they inform behaviors that shape HIV care engagement, some of which may include mental health, substance use, sexual risk behavior. And by collecting EMA data and pairing it with digital HIV care navigation, we were able to be more responsive and accountable to the dynamic lives of young people living with HIV, to provide real-time, personalized digital HIV care navigation. Our EMA intervention component included daily short text message surveys sent to participants for 90 consecutive days. Participants earned $1 per completed survey, and if they completed 80% or more of their surveys, they earned a bonus of $100. Participants were remunerated in the form of a gift card. Each daily survey included measures on the following constructs: mood, mental health, sexual risk behavior, substance use, the co-occurrence of substance use and sex, and treatment adherence. In total, a daily survey took less than 2 to 3 minutes to complete. Next, I'll show you how all these components come together. Here you see a schema of the study design. At baseline, participants meet with their digital HIV care navigator, provide informed consent and necessary releases of information for for facilitating referrals in the service system, complete a baseline assessment as well as a comprehensive needs assessment and social media contact information. And together, the participants in the Digital HIV Care Navigator work to identify behavioral change goals during the intervention period. And participants are enrolled in the EMA platform and are provided a mobile phone if they do not already have one. Participants receive 90 days of EMA surveys and 6 months of digital HIV care navigation. They also complete in-person assessments at baseline, 6, 12, and 18 months. And again, a unique component of this intervention is the interaction between daily EMA surveys and providing digital HIV care navigation. Our digital HIV care navigator was able to monitor changes in EMA constructs like mood through a dashboard and tailor the timing and delivery of digital HIV care navigation to changes in participants' daily lives. Think of the EMA surveys as a temperature read of where participants were at any given time every day. The digital HIV care navigator was able to check in, read the temperature, and respond to that temperature, especially if changes in things like mood, mental health, substance use, and sexual risk behavior, and medical adherence, adherence to ART changed. And so if there was changes in any one of these constructs, the digital HIV care navigator was able to reach out, dig a little deeper, and tailor the kind of support that young people needed in their dynamic lives. The majority of interactions were virtual, with the exception of in-person visits at baseline, 6, 12, and 18 months. And this intervention was delivered as a part of a centralized format where we served patients at multiple clinic sites, forming a digital safety net spanning San Francisco's HIV prevention and care network. We enrolled 120 people living with HIV between the ages of 18 and 34 in San Francisco who identified as gay, bisexual men or other men who have sex with men, or trans women who are either newly diagnosed with HIV or experience barriers to linkage, engagement, or retention in HIV care, and or were not virally suppressed. Now I'd like to walk you through our exciting evaluation findings, starting with feasibility and acceptability. We found that digital HIV care navigation was feasible to implement in our intervention setting with our population of focus. We were able to recruit a racially diverse sample that reflected our local epidemic at the time. 1 out of 5 were recently incarcerated, and about a third were diagnosed in the last year. We also found that participants were engaging with the intervention. In total, over 12,000 text messages were sent, ranging from 1 to almost about 500 text messages per participant conversation. The average number of text messages per participant was about 109 text messages, and we had a good spread of engagement in the intervention. To assess acceptability, we qualitatively interviewed participants at the completion of the intervention, and we found high acceptability of digital HIV care navigation among young people living with HIV. The majority of participants found that 6 months of digital navigation was a good amount of time and that it positively impacted their engagement in HIV care. We also found that the primary barrier to participation was structural inequity, and in particular experiencing acute homelessness. Next, I'll read a couple of quotes from participants. This participant said, "I was in the waiting room and actually in the doctor's office, texting the digital navigator and discussing the questions that I was going to ask the doctor, and some of the information that I wanted to make sure to tell her. I needed the digital navigator to help me remember the questions that were important for me to ask. That was the first time I actually went to my doctor's appointment prepared." Another participant said, "It made me more consistent, and it always gave me reminders. I could say, this is what's going on and this is what I need. And the response would be, this is what I think you should do. And that doesn't happen every day. You don't always have someone with that type of experience that my digital navigator had. I think about the community impact, and I think that many people who are diagnosed with HIV in the community need it." And in terms of intervention efficacy, we found very promising results. We constructed generalized estimating equation models to analyze HIV care outcomes over a 6 and 12-month study period. Immediately after the end of receiving the digital HIV care navigation intervention, we observed increased odds of viral suppression, and this intervention effect was sustained at 12-month follow-up. In models interacting intervention engagement, or the number of text messages sent between digital navigators and participants, and time, we observed that with every one text message increase in intervention engagement, this was associated with an increased odds of undetectable viral load. So the more people participated, the more they text messaged, the more they engaged, we saw increased odds of undetectable viral load. And I want to center the unique element of providing digital HIV care navigation just in time. Here, I highlight and read a conversation between a participant and their digital HIV care navigator to illustrate the kinds of exchanges and interactions that took place. This participant is describing a dream they had. On the left, he says, "I had a dream last night. Somehow I go back to his home country to visit my family and they know I have it. Then I'm on the street with strange people yelling around me. I see my mom among those people, but I can't reach her. She sees me, but moves further and I cry. I haven't called or texted anyone in my family, but no one cares. I assume they all know by now that I've deactivated my pages. I feel abandoned." Here, he is actively trying to cope with his diagnosis within the context of an immigrant experience. He equates his family's knowledge of his serostatus with distancing and potential loss. He goes on to say, "I've never regretted anything I've done in my life, but this time I regret that I met him. I'm so lost." It's clear that he is experiencing severe isolation in a very critical period immediately after his diagnosis. I'd like to also draw attention to the phrases, "I'm sorry if I'm bothering you," "I'm not needy." These phrases identify the precarious situation of his current social location and makes visible just how challenging the intersection of race, culture, immigration, sexuality, and HIV is today. And on the right, I show segments of how the conversation unfolded with his digital HIV care navigator, who used empathy and reflective listening skills to support self-efficacy and optimism. This on-demand personalized care is what young people living with HIV need to disrupt potential internalized stigma and the silence around HIV. We found and learned so much, and I'll talk about some of those lessons learned next. We found that social media contact information is stable over time compared to a phone number. And what this meant for us was that while phone numbers will often last anywhere from 3 to 6 months, finding someone on social media, friending them, or at least understanding where and how we could contact them, that social media footprint was more stable than a phone number. And that, I think, could be really helpful in your practice and in your clinical settings. We also found that using non-HIV related messages to develop rapport and build trust was really important. In the tornado of life that can happen, HIV may not be the first and only thing that a young person living with HIV is thinking about 24/7. And being able to form that rapport, talk about relationships, boyfriends, girlfriends, friendships, falling out of friendships even. Understanding and being able to center those very real and oftentimes more daunting conversations really helped us eventually get to HIV and their engagement in care. Carving out time to engage in a more lengthy text message session in real time was also really helpful. A lot of communication asynchronously through text message was helpful. However, to get deeper into the conversation, we found that it was really helpful to set up 30-minute slots or dates just to allow for questions in real time to come through, rather than constantly missing each other as ships in the night. We also found that technology was not just a means to an end. Technology is inherently social, and these meanings and this can lead to meaningful interactions. Communicating with young people through their mobile phone, through text messaging, made use of the relationship that young people have with their mobile phone. And if mobile phones are there to be a constant way to plug into one social network for young people, being present and often having a presence and having the opportunity to connect with someone from the healthcare setting, and in this case, a digital HIV care navigator, also meant that they were on demand, also meant that the interaction that young people had with their digital navigator on their mobile phone was even more meaningful. It was like talking to a friend. We also found that low tech and high touch interventions can be powerful, and we often can overlook text messaging. But we found that even though low tech text messaging may not be the most innovative or forward thinking piece of technology, it can still be extremely powerful and be high touch. We also found that analyzing intervention exposure data is increasingly challenging. And if you are a site that is trying to understand how much your patient population engages in text messaging and relating that to HIV care continuum outcomes, I'd love to speak with you more about what that might mean for you in your context and in your clinical setting. Having access to thousands and thousands and thousands of text message data was daunting to begin to unpack. So, and kudos to you all if you are taking on that challenge. And finally, I include references for works cited in my presentation. Thank you very much for your time today. If you'd like to stay in touch, please send me a note. And for specific questions to learn more about the Center for Innovation and Engagement, please send an email to healthequity@nasdaq.org. Thank you and have a wonderful day.